Hello students, this is chapter 28 in your book on wound care. The first part that you need to learn about is wound repair, and that begins on page 635. Know the steps of wound repair, inflammation, know the signs and symptoms of inflammation, which are really important because you're going to need to know that throughout nursing. That swelling, redness, warmth, pain, decreased function, those kinds of things. We also see leukocytosis, an increased production of white blood cells. Specifically, neutrophils and monocytes are responsible for phagocytosis, clearing up debris and bacteria in a wound. And you know phagocytosis from A&P, that is that cell eating. So that's the first stage. And then proliferation is when we see hopefully the beginnings of granulation tissue forming. That is that new blood vessels, fibroblasts, epithelial cells that form in the base of that wound. And that granulation tissue, remember I said, needs to look bright pink or bright red, kind of hamburger looking. And so we would see that in the proliferation period. And we would also see restoration through resolution, regeneration, or scar formation, which we did learn in A&P as well. And then remodeling, the last stage, is when the wound is pretty much healed over. It starts to contract and the scar starts to shrink. Oftentimes goes from a bright red to more of a lighter color. And then on page 636, you need to understand what wound healing is. First intention, second intention, third intention. First intention healing, the edges are brought together, kind of like a surgical incision. Second intention, the edges are widely separated like a decubitus ulcer, and we have to have granulation tissue fill in that wound, and it takes a while. Third intention, we leave those edges widely separated on purpose. Maybe there's infection or something in there, and then they're brought back together later with some kind of closure device. This type of wound healing leaves the biggest, broadest, deepest scar. Note the gerontologic considerations at the bottom of page 636 and how wound healing differs in our senior population. Wound healing complications on page 637. We could see undermining, which is erosion of tissue from underneath intact skin. Think of a cliff with an overhang. And so you have no tissue under, this is the wound edge and you have no tissue under here. So you have this overhang of skin. That's undermining. Slough is dead tissue on the surface. It looks moist and stringy, usually a yellowish tan. You see necrotic tissue sometimes, which is this dry brown tissue, and it can also be a hard-looking substance called eschar. And then you learned in the last chapter about dehiscence and evisceration of the wound, dehiscing, opening up, the edges opening up, and evisceration, the edges opening up and organs coming out. There's a really good picture at the bottom of 637 about some of the different things that you would see in a wound. You'd see granulation tissue undermining, a rolled edge. There's one word they didn't talk about was maceration, and that's when the wound kind of gets really moist looking from being wet, and it gets that white macerated look. So look that up. That wasn't in the book. Types of dressings that we use. Why do we use a dressing? To keep the wound clean, absorb drainage, control bleeding, protect from further injury, maybe to hold medication in place, and to maintain a moist environment. And we can use a variety of different types of dressings. Gauze, transparent. Transparent dressings don't really absorb. Gauze absorbs better. Or you can have those hydrocolloids, hydrogels, and alginates. And those, like your Duoderms, things that you put on, stay in place, and when the material comes in contact with a moist wound, it becomes almost gelatinous-like. So be aware of that. And then the bottom of page 638 shows a gentleman laying in bed, and he has Montgomery straps on, and right above his head there, and letter A, that picture shows what they look like. It's just like a person with an abdominal incision that has these adhesive strips along the side and flaps that have laces. So you can open the flaps, put a dressing, change that dressing, and lace it back up without tearing the tape off and on, because pulling tape off and on can bring cause skin breakdown. So Montgomery straps are very helpful, especially for abdominal incisions. Drains, the next thing. You might see an open drain, which is what we call the Penrose drain. It works by capillary action, moving the liquid to a point of contact from a wound onto a dressing. You could have a closed drain, such as a Hemovac or a Jackson Pratt. Hemovac, it looks almost like an accordion. A Jackson Pratt, we used to call a grenade, but we're not allowed to call that anymore. But you squeeze the Hemovac shut, or the Jackson Pratt, you squeeze it tight before you put the lid on it. And then that causes a negative pressure and pulls the drainage into that container. Then you open it up when it's no longer compressed, empty it. Each of those should have their own container to empty it. And we need to keep track of output with that drainage. And before you close it, you clean it, squeeze it, put the lid back on, and start over again. Another one is the Wound Vac, which we use a lot today. It has this constant suction. The wound is covered and is attached to a vacuum and pulls drainage out. And we see a lot faster wound healing with those. Know the difference between sutures and staples. Sutures more like a sewing of a thread type thing. Staples more of a metal clip. Know the difference between bandages and binders. Bandages like an ACE wrap or a binder to secure a dressing or a body part. And then also know the different types of debridement that we would see. And that's talked about on page 643. Sharp debridement, usually a physician would do that, taking like a sharp scalpel or something and pulling out dead necrotic tissue. Enzymatic debridement, using a chemical or a medication enzyme to dissolve dead tissue. Autolytic is letting the body's own tissues take care of it. It slowly softens and liquefies it. Or we can do mechanical debridement by a number of things. You can do it with maggots, and it sounds disgusting, but it works really good. The maggots have been approved since 2004, and that we put them in the wound, and they secrete an enzyme that dissolves dead tissue. You can use a whirlpool bath that can get rid of dead tissue. We talked about that with burns, I think in A&P. Or irrigation, flushing debris out of a wound. Now we can use irrigation for flushing a wound, but we can also use irrigation for flushing out an ear, and it shows doing that at the bottom of page 644. Remember, a big thing to remember when you irrigate an ear. If you're using a syringe, never totally occlude the ear canal with the tip of the syringe. If you push the fluid in with that ear canal totally occluded, you could rupture the tympanic membrane, which is also known as the eardrum. We don't want to do that, so be very cautious about that. We can do eye irrigation. There's a nice little discussion on how to do an eye irrigation on page 645. And then a vaginal irrigation, also known as douching. We rarely do that nowadays because you learn with the microbiome, vaginal flora are very important in maintaining our microbiome, and we don't want to flush them out. Then the next page talks about the use of heat and cold applications. We always need a doctor's order to use heat and cold. We have to assess the skin regularly. We need to make sure we're using appropriate temperatures for the heat and cold, that we're not damaging tissue further. And you need to make sure you're doing a 20 to 30 minute on, 20 to 30 minute off. I usually like to do 20 minute on and about 30 minutes off, 20 minute on, 30 minutes off. An aquathermia pad is a type of device that can do both heat or cold. Box 28.1 talks about the common uses for heat and cold and why you would do it. Heat promotes circulation. Cold constricts circulation, so it can control bleeding and to reduce swelling and inflammation. So we have to use it in appropriate times. That's why you need a doctor's order. And it gives you different ways you can do both heat and cold. So look those over. You can do it with chemical packs, ice packs, ice collars, soaks, and therapeutic baths. Remind yourself what a sitz bath is for and what you use that for. Person who's had a hemorrhoidectomy or a postpartum mom, sitz baths are really good for them. And then last but not least in that chapter is a discussion on pressure ulcers. It's last in the chapter, but it's a huge issue. Know what a pressure ulcer is. It's also called a decubitus ulcer. Usually forms on bony areas and areas where there's pressure located. Oftentimes our clients who are highest risk are patients who are immobile, who are older, who may not be eating as well, who may be running a fever and diaphoretic or incontinent, and having a lot of secretions, body fluids next to them. So we have to be cautious of those and make sure we prevent a pressure sore from happening. So the biggest thing you can remember is preventing it. If a person gets a pressure sore, we do need to know what stage it is. Stage 1, it's just a reddened area. Stage 2, it's red, but it may also be open with a blister, but usually if it's open, it's shallow. Stage 3, it's open to the subcutaneous level. And stage 4 is life-threatening, and usually it's exposing muscle and bone. Risk factors for developing pressure ulcers are in box 28-2, and you can see some of the an example of a stage 4 pressure ulcer right beside that box, and we don't want to see those. Nursing guidelines on page 28-2 on preventing pressure ulcer, very important. Changing somebody's position every 2 hours, lifting rather than dragging when repositioning, avoid using plastic covered pillows. Keep body parts that are bony from direct contact. Massaging bony prominences only if the skin blanches with pressure relief. Keeping the skin clean and dry and making sure we're checking our patients who are incontinent. Using a moisturizer cleanser rather than a soap. Rinse and dry well when we bathe. Keeping the heels off of the bed. Keeping pressure off of the ears if they have oxygen. Seat cushions. And then making sure if we're lifting somebody up in the bed because they've come down in the bed, especially a hospital bed, that we're not using a shearing force when we're pulling them back up. And then a big thing people forget is we cannot forget how much nutrition plays a role in maintaining healthy skin. So especially increased protein and increased calories. People with wounds need a lot of protein to rebuild that tissue. So I hope this video helped you for chapter 28. Make sure you study hard. There's a lot of really good information in it. Thank you.